So the next surgical procedure I'm going to talk is ulnar nerve transposition. So if you have not done that, so those are interesting surgical procedure where we can really make some difference and help the surgeon in this procedure. So the ulnar nerve travel in the upper extremity from CAT1 root and come down and wrap around the medial epicondyle and travel next to the ulna. So what we have to do is in clinical setting, we do nerve conduction studies, and these are done for clinical trials. It helps in providing the diagnosis if there's any problem with the ulnar nerve. The nerve is tested by stimulating in one end and recording from the other side. The latencies and the amplitude of the waveform, it identify the problem if there's any problem with the nerve or its demyelination. Some patients who are having surgery report having nerve connection study before the surgery, and it is part of their medical record, and you can find that. And that can help about how the patient will be doing in the OR, if they have any signal or not. So this is a picture. We can see the patient is lying in a clinical bed chair, and you can stimulate. You have multiple area where you can stimulate. So either you can stimulate from different points or you can record from different points. So we can see on the top, so there's a probe, bipolar hand has stimulator at the brachial plexus, and then upper arm, then elbow, and then wrist, and recording from the thinner muscle. So you can see the latencies are different. So it get longer and longer when you go up, or get shorter latency when you go more distal. So ulnar nerve transposition is surgery to relieve pressure on one arm because patients usually have the pain or numbness or tingling on one side in a small finger or ring finger. And so the nerve is moved behind the elbow to the front of the elbow. So what is ulnar nerve transposition and why it's done? It is procedure to relocate the ulnar nerve. Procedure is done because the ulnar nerve is being compressed or irritated. So the patient can have different syndromes. One is cubital tunnel syndrome, is when the ulnar is compressed at the elbow. The other common ulnar problem is carpal tunnel syndrome, where the nerve is compressed at the carpal tunnel. At the wrist, causes are unknown, but there are multiple factors that can contribute, like adjacent muscles rubbing against the nerve, a bony spur, a cyst, elbow fracture can do that. But the surgery is done after all the therapy and all the other avenue have expired. So if you're walking into the OR and you're planning to do these surgeries, so you need to have few things ready. Number one is tripolar electrode. So if you're not familiar with the tripolar electrodes, you must have the tripolar electrode. You can use the bipolar in case of emergency, but tripolar will have the least current spread and you will have less stimulation artifact. So tripolar hook electrode, which has anode on the side and cathode in the middle for stimulation, and then bipolar electrode to record. So the bipolar is used to record. Subdermal needles are used for recording EMG, and then you can do trigger EMG, trainer 4, and evoke potential for recording. Different muscles we can use our flexor carpi ulnaris because all the forearm and hand muscles are used. Flexor digitorum profundus, abductor digiti minimi, lumbricals in the hand, and abductor pollicis brevis, and thinner and hypothinner muscles are done, recorded. So the APB is done for control because APB is usually supplied by the median nerve. So the case usually starts surgeon is exposed, and then they locate the nerve and may want to test it. So the first testing is typically done by trigger EMG, so you can do regular monopolar fine tip stimulation. Once you've identified the nerve, this nerve is exposed and elevated. So you can use, then we do nerve conduction velocity test. The surgeon will tell us the distance between the two stimulation recording electrodes. So we measure the difference between the one tip to the other tip, so for many centimeters, and use this measurement for nerve conduction velocity calculation. So it's very important to know that before you make any decision. So once we have the nerve, nerve velocity test done, the nerve is decompressed and then relocated the nerve. The second velocity, nerve conduction velocity is done, and then calculate the nerve velocity to see if there's any change in conduction. Is there any improvement or not? So this, it's not always there's improvement. Many times you'll have no improvement, especially with a chronic irritated nerve. Once it's done, we had the response, then we close and then the case continues. So in order to do, we need to have some math idea, because it is not yes and no, because we have to calculate that. So distance divided by time in velocity. So first convert centimeter into meters. So because the distance is giving into centimeter, the speed of the nerve velocity is always meter per second. So, but we have centimeters, so we have to convert the centimeter into meters, and then second convert millisecond into second. So then we have to calculate how many milliseconds it takes to a second, and that will be meters per second. So if you are stimulating here at the elbow and recording at the wrist, so 0.3 meters. So if it is 0.3 meters per 0.006 second, that will be 50 meters per second. So if it is if the distance between the active stimulating and recording electrode is 3 centimeter, then that is 0.3 meters. And if it's 6 centimeter, it becomes 0.0. It takes 6 millisecond. It will take 6 divided by 1000 is 0.006 second. So 0.3 meters divided by 0.006 second will be 50 meters per second. So this is one of the example of the case we did. So this patient, a 60-year-old patient, right hand male. Patient presented with numbness to the hand and forearm and tingling worse on fourth and fifth digits. Patient denied any weakness. He fell 3 years prior to having during a backpacking trip and lost strength in his right arm. The nerve conduction study was done in clinical setting and it shows no response to the ulnar nerve. The neurologist did not believe it was related to the neck. Patient right arm was a limb to be operated on, so it was a right arm surgery. The team decided we would be ones placing the electrode on before the arm. So the technologist and the neurophysiologist in the room, they place all the electrodes and the person take a dump before the surgeon was covered these electrode with the tegaderm and prep the skin. So you can see all these muscles. So we have this area where there's triangular. So that's the exposed part with medial epicondyle, and then we have flexor carpi ulnaris recording electrode. We have flexor digitorum profundus recording, abductor digit mini at the wrist. APB is done for control and lumbrical. So those are the minimum recording. So large two decaderms were placed additional electrode. So the surgeon exposed the area, identify landmark like medial epicondyle, and locate the compressed area of the nerve. So you can see this area. So at this time, we make sure we have the brass probe is plugged in, the one single monopolar electrode is plugged in, and we also have bipolar electrode is plugged in. So these are bipolar electrode, they come in different sizes. So you want to have a right angle. We don't want curve because it's difficult to produce the curve, especially, and you want the smaller diameter. So the tripolar electrodes are best ones for stimulation, but so if you're doing trigger EMG, you can use bipolar stimulation or you can use a monopolar stimulation, and it gives us the location of the nerve, identification of the nerve, and see if there's a motor fiber conducting to the nerve. So once we go to the EP window and we run nerve conduction test, and when the surgeon is ready, place stimulating recording electrode for a distance more than 4 centimeter. So it's recommended that you should have more than 4 centimeter, because if you're less than 4 centimeter, the stimulation artifact is huge and you may not be able to get response. So in this case, we were stimulating at 1 milliampere, and the peak response was at around 11.25 millisecond, and the gain was 100 microvolt per division. So we asked the surgeon what is the distance, and the surgeon told us that is a 5 centimeter. So the peak was 11 milliseconds, so 0.5 meter plus 0.001 a second became 45.45. So the conduction then of this nerve was about 45 meters per second. So this was followed by the decompression of the nerves, the surgeon decompressed the nerve. And after the rerouting of the nerve, we did again nerve conduction study. So the probe is placed in reverse direction. So that's why the peak is upside down. So again, we got the response at 1 millisecond, milliampere, but the inverted peak instead of because probe was held in a different, the active and reference they switched. The interpeak was the peak was about 8.25 millisecond and the gain was 1000. It was a huge response. So when we made the calculation, so 5 centimeter divided by 8 millisecond, it came to 62.5 meter per second. So before the transposition in this patient, the nerve conduction was about 45 meter per second, and after transmission, we were getting recording about 62.5 millisecond.